on IBD mimics by Dr. Rupa Banerjee. I'd like to introduce our chairpersons, Dr. A.C. Anand sir. Sir is at the Kalinga Institute after retiring from Army, and he is one of the most exceptional gastroenterologists in the country. We also have Dr. Gaurav Muktesh, who is Assistant Professor of Gastroenterology at PGI Chandigarh. Again, I'd request the chairpersons, because we are short of time, to not take any questions. Over to you, chairpersons. Thank you.
Can you hear me? Can you hear me?
Yes, sir. Yes.
Okay. I am grateful to the PGI team for giving me this opportunity. And the talk is on IBD mimics. And the speaker is none other than Dr. Rupa Banerjee, who needs no introduction to the IBD crowd. She is one of the most lucid speakers on the subject of IBD, and she is the director of Inflammatory Bowel Disease Clinic at Asian Institute of Gastroenterology. Since I have been already warned by the organizers about the time, I will not take much time in introducing her. I'll request Dr. Banerjee to kindly give the talk.
I need screen sharing.
You can share, madam. It's allowed for everyone.
Thank you, Dr. Anand, for the kind words of introduction. And thank you, Dr. Usha. Thank you, Dr. Vishal, for giving me the opportunity, the entire PGI team. The topic is huge, and I already gathered time is short. So we're just going to go run past a few slides and just take back how it impacts our clinical practice and what we need to do for mimics of IBD. We know traditionally IBD was a disease of the West. We were far away, happy in our own world, developing world. This was the land of infectious diseases. And we thought that this is what we needed to focus on. This is the land of infectious diseases. As you can see, the tuberculosis, the diarrheal diseases, all over the region. We were busy combating infections, the main ways to prevent infection, the polios, the vaccinations. This was while we were doing this, IBD numbers, they remained low up to the 80s. Post the 80s, there was this globalization. But what did we get? We got bad air, the concrete jungle. Our diets changed. We became obese. We don't know what exactly happened, but IBD came to the non-Western world. In this scenario, IBDs were chronic, lifelong, complex diseases. Symptoms are often non-specific: abdominal pain, diarrhea, rectal bleeding, all very common in our region anyway. Differential diagnosis is broad, encompasses a wide spectrum of diseases which can mimic or even coexist with IBD. And if you see the top etiologic considerations, you will find infections right at the bottom. But I thought, since we are speaking in the Asian region, India and our land, the focus today first would be the infectious mimics of IBD, and then quickly we will run past the non-infectious mimics. Southeast Asia today is an emerging infectious diseases hotspot that has not come down, and IBD is on the rise. So infectious colitis and IBD together are two lions in the same region, a common encounter. What are the infectious mimics? There are a long list: the bacterial enteropathogens, the mycobacterial, the sexually transmitted proctocolitis, our age-old Amebiasis, name it and it is there. Amidst the bacterial enteropathogen, stool culture for bacterial infection can actually yield a variety of organisms. So Salmonella is the first, non-typhoid Salmonella species. Foodborne pathogens from dairy and meat products. Symptoms: bloody or non-bloody diarrhea, fever, headache, and abdominal pain. Higher incidence of non-typhoid salmonella infection in IBD as well, may be associated with reactive arthritis. Just to highlight that, it's difficult to differentiate from IBD proper. Treatment, of course, is recommended for typhoid and severe non-typhoid salmonella. Fluoroquinolone resistance is common. Macrolides or extended spectrum cephalosporins are therefore preferred. So this is salmonella. Then we come to Shigella. Here again, symptoms can be fever, bloody diarrhea, abdominal pain, and myalgias. Severe cases can present with as a megacolon. Extraintestinal manifestations are known, particularly reactive arthritis, sepsis, seizures, hemolytic uremic syndrome. Treatment is with antibiotics. Again, for our setting, we need to rule these infections out based on the symptoms, particularly if fever is high. Then we have the enterohemorrhagic E. coli. Here, again, bloody diarrhea, abdominal pain, but treatment-wise, avoid the antibiotics, narcotics, anti-motility drugs, and NSAIDs, because use may potentially precipitate development of hemolytic uremic syndrome by increased release of Shiga-like toxin. So amongst these infections, for E. coli, perhaps antibiotics need to be avoided, and we need to be careful on that side. Yersinia enterocolitica, but we don't see too much, but they are great mimics. If you see, they manifest as enterocolitis with diarrhea, fever, abdominal pain, endoscopic findings, terminal ileal cecal ulcerations. Notably, they can also present as granulomatous ileitis, therefore often misdiagnosed as Crohn's disease, may have extraintestinal manifestations. Treatment is simple, not a lifelong treatment, just fluoroquinolones, third generation cephalosporins. But we need to suspect, we need to think, and we need to rule out. Campylobacter is on the rise. It is also a cause of diarrhea in patients with IBD who commonly present with fever, weight loss, and abdominal pain. Extraintestinal manifestations include the GB syndrome. Campylobacter is one of the leading etiologies. There could be reactive arthritis. Once again, treatment with macrolide or fluoroquinolone antibiotics. We recently actually had a patient with Campylobacter on culture. That is the first case that I can think of. And then the patient did respond well to antibiotic therapy. We come to amebiasis. And we should never forget that in our part of the world, 10% of world's population is infected. Most of it is in the tropical region and classically presents with abdominal pain with bloody diarrhea. Symptoms vary from asymptomatic cyst carrier to fulminant colitis. Colonoscopy can show right or left-sided colitis. And we always learn the hard way. Now that we are seeing a lot of IBD, and this was a very interesting case because this was a patient with ulcerative colitis with a flare, not responding to steroids. We were planning to go beyond. A biopsy actually showed that it was teeming with amoeba. So history, family history, taking the histopathology was always necessary because unfortunately infections are prevalent and it's bad to miss one, because these are treatable conditions and treatment makes all the difference. Again, this is another patient with ileocecal ulcerations with a loss of vascular pattern, granularity, pinpoint erosions, few superficial ulcerations. Biopsy told us that it is a strongyloidosis. Fulminant amoebic colitis after corticosteroid therapy. Hence, this is a study of 24 cases identified of intestinal amebiasis with concomitant corticosteroid therapy. And I'd like to highlight here that 25% cases turned out to be fatal. 46% or 11 of these patients were given steroids for misdiagnosed inflammatory bowel disease. I think in India, we are much more cautious anyway, but biopsies and follow-up, once a patient is not responding, is actually a must. Sexually transmitted infectious proctitis or colitis is known. They can be misdiagnosed as Crohn's disease. There are subtle histological differences between STI colitis. In fact, if you see here, there's a fairly intact colonic architecture. But on the other side, in Crohn's disease, there's prominent architectural disturbances. But normally, we don't need to rely on the pathologist or endoscopist for this diagnosis. The history is perhaps the most important to ensure prompt diagnosis and treatment. So amidst the infectious mimics, I always need to mention TB, tuberculosis, and mycobacterial infections, because this is one of the 4 top situations where you should take a second medical opinion. And this was, a few years ago, put up on CNN. And if you can see brain tumors before surgery, take a second opinion, but decision dilemmas before treatment of tuberculosis versus Crohn's disease, you do need to take a second opinion, meaning it is so difficult to diagnose or differentiate between the two. This has been a topic which we keep discussing at every IBD meeting, but you just cannot get across that because the extent of the problem is huge. TB is one of the most common infections in the emerging world, and 90% of infected patients develop latent rather than active disease. And anti-TNFs may increase the risk of developing TB 5-fold. We need to differentiate. The increasing Crohn's disease, in fact, has created a strange dilemma. Earlier, we were diagnosing Crohn's disease less because we were treating it as TB. And now the opposite is also increasing. Cases of Crohn's disease misdiagnosed as TB have been decreasing, but cases of TB misdiagnosed as Crohn's disease is actually increasing over the past 2 I'm sorry, this is this causes diagnostic delay, and then there is increased risk of complications because of this factor of the TB versus Crohn's. Anti-TB therapy prevented early diagnosis in almost 1/3 of the patients that we saw at our institute. Interestingly, many will respond partially or even completely to TB treatment. They turn out to be Crohn's later on. So despite initial clinical response to anti-TB therapy, long-term stenotic complications are higher. We follow a treatment algorithm, treat like TB or treat like Crohn's disease based on clinical judgment, basic investigations, and then follow up the patient. If TB culture comes positive, patient is on TB treatment, complete therapy. TB culture negative, poor clinical response, re-evaluate. TB culture negative, but clinical improvement, then you need to complete therapy and then reassess to rule out Crohn's disease. The next mimic that we need to focus on is infections that mimic a flare in IBD and the impact on IBD therapy, because we need to understand when there is a mimic which is looking like a flare of IBD, which should mandate a discontinuation of therapy, and when can medications be continued. And first and foremost is CMV colitis, and I think Dr. Saurav has just gone into it in detail. The dilemmas we know, is CMV the culprit or the bystander, to treat or not to treat, and what about the immunosuppressants? Once again, I will not get into it. If biopsy is negative, patient is responding to steroid, continue the treatment. If steroid resistant and disease is severe, start antiviral therapy. But if blood is positive, not responding, then stop immunosuppressants, start antiviral, consider colectomy. So this is all in short, but we need to understand, I think Dr. Saurav has covered it in an excellent way in his talk. And then we come to Clostridium difficile. And this is a clipboard case, a 41-year-old you see in remission on an adalimumab. Colonoscopy showed the classical findings. C. diff toxin was positive. C. diff can produce symptoms that mimic a flare. It can precipitate a genuine flare or just be an innocent colonizing bystander. And that is the enigma of IBD. What should we do? Withhold immunosuppressants, prescribe antibiotics alone, or administer antibiotics together with continuing immunosuppressants to treat the possible exacerbation of IBD. And to put it in short, and I've just put it up there because there's a significant disagreement on whether combination of antibiotic plus immunomodulators or antibiotic alone should be the treatment. Clearly, the risk and benefit has to be balanced and individualized. But importantly, both CMV and C. diff should remember what to do. There are management algorithms, but within 72 hours of CDI therapy, we need to assess clinical status unchanged or worsening. Based on that, we can proceed further. The next that we come into after all this huge list of infections is the non-infectious mimics of IBD. And I think this is also important. The first, and we'll just go slide by slide on a few practice points only. Diverticulitis, most often presents in the left colon with acute left lower quadrant abdominal pain, do not usually have diarrhea and bleeding, unlike IBD. Cross-sectional imaging recommended, can be diagnostic. Practice point here, endoscopy to be avoided if you think so because of risk of potential bowel perforation. Then we come to the segmental colitis associated with diverticulosis. Here it may manifest as abdominal pain and diarrhea. Histology may be consistent with cryptitis, cryptabscess, evidence of chronicity, very much like Crohn's disease. How do we differentiate? Here, endoscopically, inflammation usually occurs in areas of diverticulosis alone, and the rectum is spared. Patients will respond to topical and or mesalamine treatment. Then we are seeing more cases as more surgery is happening. That is the diversion colitis. The incidence of diversion colitis has actually been estimated to range between 50 to even 100%, may occur as early as 3 months following surgery. A deficiency of butyrate or the short-chain fatty acid is considered to be the main factor. The majority here again will present with abdominal pain, rectal bleeding, discharge, and tenesmus. Endoscopic features, very difficult to differentiate, can just be friability, erosions, and ulcerations. Usually responds best to reversal of ostomy. Short chain fatty acid enemas have been used. I don't have a personal experience, but may work. We come to NSAID-induced enteropathy. This is one area I think for all practicing physicians as well as practicing gastroenterologists is increasingly becoming important, and I'll spend a couple of minutes on this because majority of cases are subclinical, at least initially. Symptoms and signs of ill health are often attributed to underlying disease alone. Possible evidence of NSAID enteropathy: dyspepsia that does not respond to PPI, a vague abdominal pain, iron deficiency, anemia, obstructive symptoms only when strictures develop. And if you look at the spectrum of small bowel NSAID ulcers, single or multiple, superficial, punched out, deep, confluent, very difficult to say whether this is IBD or not. Diaphragm disease, this is common when you're taking NSAIDs with enterohepatic circulation, and this perhaps would give us the first inclination that NSAID usage is the cause. So gastroduodenal side effects and bleeding of ulcers are well known, but right now we need to focus on NSAID-induced small intestinal ulceration, and all ulcers in the small bowel are actually not Crohn's or IBD. Polypharmacy is shifting GI injury more distally. And if you see, when used alone, NSAID, or when used with a combination of other drugs, the small intestine takes the major hit. PPIs actually exacerbate NSAID-induced enteropathy. And gastric acid suppression by PPIs do not protect against small intestinal damage. They aggravate small intestinal damage by altering the enteric microbial profile. Misoprostol, sulfasalazine can be protective, but still inadequate data to show that. The other important thing, prolonged exposure causes more damage. So all the enteric coated aspirin that we use actually causes more of small intestinal damage because it dissolves in the proximal small intestine and allows aspirin to contact the mucosa at a high concentration. So enterohepatic circulation of NSAIDs contributes to SI damage by, again, prolonged exposure. These are facts which we need to know more in practice. Other than this, quickly to go through, radiation can cause small intestinal ulcers, neoplasms, T-cell lymphomas, primary neoplasms we should not miss. There are other inflammatory diseases, jejunoileitis with celiac disease, eosinophilic enteritis, Behçet's, we can all look like IBD. Collagen, vascular diseases, multiple vasculitis. So there is no distinct appearance of the ulcers. If you see a patient who had taken NSAIDs or a capsule image from a patient post-radiation, the endoscopic appearance is rarely diagnostic. Biopsies are usually non-specific, best managed only after underlying etiology has been identified. So this, we had a 20-year-old boy with bloody diarrhea, CT showing short segment thickening, multiple erosions with extensive ulcers in D3 and proximal jejunum. And then he presented with the leg lesions. Of course, it turned out to be a Henoch-Schönlein purpura severe. Ulcerative jejunitis in celiac disease. These are perhaps rarer, but we should not miss it. Usually seen in patients with unresponsive celiac disease and not seen in gluten-responsive disease. Radiation-induced small bowel disease is also important. 90% of patients who receive radiotherapy develop a permanent change in bowel habit. Can appear acutely in 2 weeks or in chronic forms up to 5 years to 6 years after therapy. Damage related to dosage, size, site of field, use of concurrent chemotherapy and radiation implants. So radiation enteritis actually can present with the entire spectrum of inflammatory bowel disease because of ischemia. There can be mucosal ulcerations, spontaneous small perforations, fistulas, and abscesses. For malabsorption, like small bowel, diarrhea, steatorrhea, weight loss, cachexia. And for the healing, again, there can be fibrosis, narrowing, and strictures. These are the things that we need to keep in mind. Chronic radiation enteritis, very little treatment available, surgical intervention if intestinal obstruction or perforation, enteroscopy and APC perhaps for small bowel telangiectasias, vitamin E, aminosalicylates, some promise, not enough. We cannot end without mentioning non-specific or idiopathic small intestinal ulceration. Ulcers beyond the jejunum that cannot be explained on the basis of any known etiology, initially reported by Mayo Clinic in 59 patients treated over 2 years. So we call it CMUs, cryptogenic multifocal ulcerous stenosing enteritis. There are a few factors by which you can differentiate. The disease process, transmural ulcers are classical in Crohn's disease. In CMUs, it's usually shallow ulcers. There's absence of small intestinal fistula formation despite recurrent chronic disease, localized largely within the jejunum or proximal ileum. So it's difficult to identify, but if you know of it and you see some patients, you know how to deal with it. Treatment, segmental resection. Some have responded to glucocorticoids. In our series of 8 patients, they responded well to budesonide. 2 have recurrent anemia requiring transfusions, and 1 after segmental resection as well. I'll end today with a diagnosis. So this is a farmer who presented with chronic right lower quadrant abdominal pain. The result of stool examination was positive for blastocystis. A colonoscopy showed these large amounts of egg-like tan ovoid objects. initial histopathology, they suspected it was a parasite, but could not identify what the parasite was. Actually, it was just undigested royal quinoa seeds. So we need to understand, and there was a nice commentary on this case which said that, it is marvelous how observation of the unusual leads to speculation, which in turn promotes inquiry and research and advances our knowledge. Here, just because it was looking like those ovoid structures, it was not blastocystis. It does not have such egg-like structures. It was just quinoa seeds, which we got from after taking a detailed history from the farmer. So the take-home messages are simple. Always alternatives or mimics must be considered when high dose of steroids does not work, or history is not fitting into classic inflammatory bowel disease. A careful look will help diagnose and ensure adequate and optimal management. We need to spot the difference. And if you see between these two, the beetles crossing the road looks like no difference. But if you look closer, there is one where there are no shoes. So thank you once again for inviting me. And I think that we will continue to learn about IBD at the master class.
Thank you, Dr. Rupa. That was an extensive expression of all the IBD mimics. This would actually invite a lot of interesting discussion, but I think the organizers are getting a little restless about the time, and therefore I request my co-chairperson, Dr. Gaurav, to close the session.
Thank you, Dr. Anand. I agree.
Thank you, Dr. Rupa. It was a wonderful and a lucid talk. I'm sure it would have enlightened so many residents and gastroenterology fellows who would probably think of only tuberculosis, Crohn's, and ulcerative colitis as the differentials. So it is a vast array. And I think we would like to close the discussion on that note. And thank you so much for being a part of this wonderful discussion. Thank you, ma'am.
Thank you.
Thank you very much.
Thank you.